Hello guys. Hi, good evening. How are you? Is my voice audible? Everything is clear? Yes, good. Okay.
Hello guys.
Okay. So we'll start with today's session. Good evening and welcome to one more live session where we'll be discussing regarding drugs used for heart failure. See, I'll just keep it as simple as that because heart failure, drugs used for heart failure, we have multiple different classifications which are involved here. For example, we will be talking about certain diuretics. We will be talking about anti-diabetic drugs, and we'll be talking about what else here, digoxin like digitalis. We'll be talking about beta receptor agonistic agents. Lots of and multiple different topics are involved as per your heart failure is concerned. We'll start with the basic pathophysiology of what exactly is heart failure. See, as far heart failure is concerned, understand this, there is going to be decreased cardiac contractility. So there is going to be negative inotropic responses. There is going to be a negative inotropic response, and because of it, the cardiac output is going to be decreased. That is the primary response of it. See, as we have already explained in many different sessions also, buddy. I think Dr. Azad is there. Azad, hi, good evening. Hi, okay. So I'm just not seeing the messages, buddy. I'm sorry for that. Okay, as we are already explaining about lots of concepts. Hi, Karthik. Good evening. Hi, good evening. Okay. So as I've told, I think I'm repeating those status again and again. We'll start with the session, buddy. See, whenever the cardiac output is getting damaged, it might be of two different types. It might be a systolic heart failure or it might be a diastolic heart failure. Systolic heart failure means the heart is unable to pump out enough amount of blood. The heart is unable to pump enough amount of blood. The contraction is going to be failed. Whereas diastolic failure means the heart is unable to relax properly. That's the concept of it. Systolic failure, heart is unable to pump out efficiently, and diastolic failure means heart is unable to relax to a complete extent. So thereby blood is not going to be stored up over there. Any issues, the cardiac output is going to get damaged. When the cardiac output is getting damaged, what's the next step? Of course, the BP is going to be falling down. The patients will land up in hypotension. And when the patient lands up in hypotension, what is the brain's phenomenon? Brain will start stimulating two major complexes. The brain will start stimulating the compensatory mechanisms. Number one, it will stimulate the sympathetic autonomic nervous system, and it will stimulate renin-angiotensin-aldosterone system. SANS will be stimulated and RAAS will be stimulated. What is the further process of it? Whenever sympathetic autonomic nervous system is getting stimulated from the brain, a switch will be switched on. A neuron is going to be coming up over there nearby the cardiac muscles. Adrenaline will be released. And this adrenaline or even the noradrenaline, if it is getting released, it will bind with beta-1 receptor, which is present over the cardiac muscles. When it is binding with the beta-1 receptors, it will try to increase the cardiac contraction. It will try to increase the heart rate. There will be positive inotropic and positive chronotropic response. The cardiac contraction will be increased, and the other one, the heart rate will be increased. It will try to correct that issue. Good. But at the same time, you know what happens? It also, the same neurons which is stimulated from the sympathetic nucleus will be acting up on the blood vessels. So what happens? Blood vessels will be starting to contract. When the blood vessels starts to constrict, what will happen? Because of arteriolar constrictions, the BP will rise. And because of venoconstriction, the blood which is coming back to the heart also will be raised. So there is going to be vasoconstriction. We'll discuss that in a few minutes. What is the clinical implication of the vasoconstriction? The second one, RAAS system is going to be stimulated, right? Whenever RAAS system is getting stimulated, as the name itself implies, renin-angiotensin-aldosterone system is going to be stimulated. So what happens? Sodium and water is going to be retained back. When sodium and water is getting retained, potassium is going to be let out. When sodium is getting retained, potassium is going to be let out from the body. This is a normal physiological phenomena of how the mineralocorticoids, especially the aldosterone, is going to be producing its mechanism. Sodium is going to be retained. So what will happen? Along with that, water also is going to be retained. There will be sodium and water retention. Beautiful. When sodium and water is getting retained, there is going to be again increased blood volume. The blood volume will be increased. And when the blood volume is getting increased, and of course, there is going to be vasoconstriction too. Whenever there is increase in the blood volume in the periphery, what will happen? Because of the vasoconstriction which is occurring because of sympathetic system also, all the blood which are pooled in the periphery will be moving back inside the heart. Fantastic mechanism. Good thing if a patient is not suffering from heart failure, because now the patient is suffering from heart failure. We cannot risk that. Why? Because I'll explain that. Because of this increased blood volume and because of the increased vasoconstriction, the venous return is going to be increased. Venous return will be increased. So what happens, buddy? When the venous return increases, the load which is happening to the heart is going to be increased. What are the loads which we know? We know two loads, right? Preload and afterload. Preload is nothing but the amount of blood which is present inside the ventricles, like nothing but end diastolic volume. End diastolic volume is nothing but the preload. Just a small recap of your physiology, buddy. Preload is nothing but end diastolic volume. The second one, what about afterload? Afterload is nothing but the pressure required to open the aortic valve. Or we can put it up in a different terminologies. The ventricles are there. We have the aorta which is coming out of it. And the aorta or the arteries will be constricted. There will be a resistance which is developed over there. The ventricles has to constrict in a forceful manner so that the aortic valve is getting opened and the blood is going to be flown inside the blood vessels. Now, how this movement is going to be happening? It will be happening against the resistance which is developed due to those blood vessels. And the resistance or the pressure required by the ventricles to push the blood out from the ventricles into the aorta, that is what called as afterload. Afterload is nothing but a pressure value, buddy. Afterload is a pressure value. So simply put, we can put up preload will be decreased. Preload will be decreased by a venodilator, whereas afterload will be decreased by an arteriolar dilator. Preload will be decreased by venodilator. Afterload will be decreased by an arteriolar dilator. So simple, so direct. Don't worry for that. Don't get confused with those concepts. So what happens when you give a venoconstrictor agent? The preload will be increased. When you give an arteriolar constrictor agent, the afterload will be increased. Just remember with this mnemonic, A for A, buddy. A is for A. Afterload is decreased by arteriolar dilators, whereas the vice versa, preload will be decreased by a venodilator agent. So here what is happening, buddy? We have finished the basics about the physiology of it. Now let's talk about the pathophysiology of it. So what is the issue which is happening here? Because the venous return is getting increased, more amount of blood is moving back to the heart. So what load will be increased, my dears? Beautiful. Preload will be increased. Preload will be increased. And because of this vasoconstriction which is happening, the blood vessels are getting constricted. Also, the arteries will be constricted. When the arteries are constricted, the blood pressure will be raised, which in turn will be increasing the afterload. There will be increase in the afterload. So both preload will be increased, afterload will be increased because of this particular issue, that is stimulation of sympathetic and RAAS system, which in turn is going to be producing further load on heart, thereby further worsening the contraction. Thereby the cardiac contraction will be further worsened because the heart is unable to pump out even a amount of blood, right? What if you put too much load on heart? Again, the contraction is going to be more decreased. So compensatory mechanisms which are trying to correct the issue. What is that issue here? Hypotension. And the compensatory mechanisms are making things worsen. That's the concept here. So how to prevent these things from occurring, buddy? So what exactly is the treatment phenomena for a patient with heart failure? What is the objectives of it? We have three important objectives. Number one, I have to increase the cardiac contraction, also called as positive inotropic response. And the second one, I have to decrease preload and I have to decrease afterload. That's it. तो क्या करना पड़ेगा हम लोग? Cardiac contraction जो हो रहा है, we have to increase it. or preload and afterload, which is primarily due to the venodilations, venoconstriction, arterial constrictions, we have to decrease it. Well, that's the concept behind. So how do we do that? For example, if a patient is presenting up with acute heart failure, presenting with symptoms, breathlessness, dyspnea is there, and it's progressing on. Patient couldn't get any revoxness from that particular symptoms. How do we treat that? Of course, patient will be suffering from hypoxia. The patient's oxygen will be very much lower. The patient's saturation will be very much low. We have to supply the oxygen for it, number one. Next, we have to decrease the load on heart. I have just take a big bunch of fluid from the body and throw it out, right? How do I do that? I just take out the blood from the patient. Don't do that. We are going to be taking out the water from the patient by administering furosemide. Furosemide, a commonly used diuretic, buddy, hum kehte hain Lasix because it's a brand name for it. Lasix, why? Because it lasts for 6 hours. That's the reason for the brand name itself. Furosemide, then we have to give 𝗏𝗏𝗃𝗏 and milrinone can be administered. Yep, furosemide, Gopi, right. So we have a 4 set of treatments for patients with acute heart failure. We have oxygen can be given, furosemide can be given, 𝗏𝗏𝗃𝗏 and milrinone. Here, what we are going to be looking at is what exactly are those individual drugs and what are the pharmacological aspects behind those. Before going into that, let's look into what exactly is the treatment for chronic heart failure, or to say drugs which might decrease mortality. Drugs which are decreasing mortality. So why the mortality is getting decreased? The concept here is, good evening, Gopi, good evening, Ashwin. Thank you so much for joining. So as per the chronic heart failure is concerned, as I've told, to decrease the mortality. Why is there a mortality? Because see, all these things are happening. The renin-angiotensin-aldosterone system is getting stimulated. That renin-angiotensin-aldosterone system in turn is going to be stimulating something called as ventricular hypertrophy. The ventricular muscles, it will think that the cardiac muscle is not contracting properly. Well, that's the reason why the patient's cardiac output is getting damaged. So when the renin-angiotensin-aldosterone system is getting stimulated, this angiotensin in turn will be having one more secondary mechanisms. It will try to proliferate the ventricular muscles. Ventricular hypertrophy will tend to occur. See, consider here is where the ventricular muscle is. Central part is where the space where the blood is going to be. When the ventricular muscles are getting hypertrophied, we can see the gap which is present in between is constantly decreasing, which means the cardiac capacity itself will be decreased. This is what we call as cardiac remodeling. Cardiac remodeling is primarily due to ventricular hypertrophy. So we have to give some drugs which should prevent those ventricular hypertrophy, buddy. We have a list of drugs. We have many different drugs, buddy, but currently I'm going to be giving you a mnemonic to remember those drugs which are used in practice. And that is BSAM drugs. Broad spectrum antimicrobial drugs. BSAM drugs, not broad spectrum antimicrobials, they're just a mnemonic. B stands for beta blockers. S stands for SGLT2 inhibitors. Recently, it has been found to be very much effective in preventing the mortality in patients. A stands for ARNI drugs. We'll discuss about that, don't worry. Yes, Dr. Gopinath, you were talking about MBBS. Yes, that's also one of the mnemonics which we use for explaining that. But currently, we are going to be adding certain newer drugs. So we are going to be changing that. You can also follow the same mnemonic, no problem. You can just include all the drugs which is going to be there itself, don't worry. And M is for mineralocorticoid receptor antagonist agent. Mineralocorticoid receptor antagonist agent. And I'm having a question here, buddy. Time to take a question. Dr. Dinakar is asking, carvedilol can be used to prevent remodeling. Yes, we can use. We can use beta blockers to prevent the remodeling, but it should not be used as the first line treatment of choice. It has to be given as an additive therapy. Good. A patient should never be put on a single beta blocker, because when you give a beta blocker, the compensatory responses like sympathetic system, that alone is getting blocked. What about the other compensatory response, renin-angiotensin, that is not getting blocked. So we have to make sure that we target both RAAS and the sympathetic system, Dinakar. I hope I have answered that question to you. Now we have this BSAM drugs, which is beta blockers. We have SGLT2 inhibitors, ARNI drugs, and we have MRA. If a patient cannot be administered ARNI, then we can opt for AC inhibitor or an ARB, angiotensin receptor blocker. We have four major set of drugs, buddy. Here we have oxygen, furosemide, dobutamine, and milrinone. Here we have beta blockers, SGLT2 inhibitors, RAAS inhibitors, simply we can call them as RAAS inhibitors, and we have MRA, mineralocorticoid receptor antagonist agents. Let's start with individual drugs. Start with the treatment process for acute heart failure. I told we started with oxygen. The second drug is going to be furosemide. What exactly is the mechanism of action of furosemide? Consider we have the glomerulus, proximal convoluted tubule, we have the descending limb, the loop of Henle, we have the thick ascending limb of Henle's loop, and distal convoluted tubule, which in turn is going to be draining to the collecting duct. We have the afferent arteriole and we have efferent arteriole, afferent and efferent arterioles. When you administer, for example, furosemide for a patient, this furosemide will gain entry inside the urine. How it is going to be gaining entry? We have certain peritubular capillaries. This furosemide will gain entry via tubular secretion. This is an important statement, buddy. Furosemide will gain entry inside the urine by tubular secretion, which means from the blood, it gains entry directly inside the proximal convoluted tubule. It is not dependent on the glomerular membrane for the drug to gain entry inside the urine. That's the reason, even if the patient's glomerular filtration rate is very much less, I can give furosemide. Furosemide will be the diuretic of choice in terms of a patient with renal failure. I hope you're all there with me till now. Good. Furosemide in turn gains entry inside the urine. From there, it will go inside the thick ascending limb of Henle's loop, where we have a specific transporter here. The function of the transporter is to produce reabsorption of sodium, potassium, and two chloride molecules. This is what called as SPCC, buddy. This is called as SPCC, or sodium potassium 2-chloride co-transporter. Furosemide is a drug which tend to inhibit this particular transporter. So what happens, buddy? Sodium and potassium is not getting reabsorbed. Sodium, potassium, chloride, all these molecules will be let out into the distal convoluted tubule. We have sodium and potassium in the distal convoluted tubule. But normally, whenever from the posterior pituitary, there is something called as antidiuretic hormone. The function of this antidiuretic hormone is to produce water reabsorption. That's why it's called as antidiuretic hormone. You would have guessed it. Antidiuretic hormone will induce water reabsorption from the urine, because there is too much amount of salt which is present in the urine itself. To prevent the urine from becoming concentrated enough, this ADH secretion will be inhibited. ADH secretions will not happen, and the receptors which is present on the distal convoluted tubule will not be activated. So what happens? Along with sodium and potassium, water also will be let out from the body. Sodium, potassium, water also will be let out from the body. Is that clear? Now, are these the only ions which are going to be thrown out? No, multiple other ions is going to be excreted out, which we'll discuss it separately under a diuretics topic. Right? So it might produce hypocalcemia, hypomagnesemia, hypokalemia, hypochloremia, lots of different things that are administered. But we'll be discussing further about that under diuretics. But anyhow, I'll just give you a basic explanation of it. This furosemide might be associated with hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia, hypochloremia, hypovolemia. All these molecules will be thrown out from the body. All these levels inside the blood will be decreased because of furosemide. It is a high ceiling diuretic. It is a loop diuretic. Why is it called as a loop diuretic? Because it is acting up on the Henle's loop. Beautiful concept. Now, apart from that, it also produces hyperuricemia, It also produces hyperglycemia, hyperuricemia, hyperglycemia, and it is associated with ototoxicity when used for a longer duration and at very high doses. Ototoxicity also can be expected with these drugs. Good. With a simple diagram, we could have explained about the what is the mechanism, how it is getting secreted, and how it is going to be utilized for renal failure, and what are the adverse effects of furosemide. By increasing the water excretion from the body, by increasing the salt excretion from the body, what will happen, buddy? The blood volume tend to be decreased. That is the primary mechanism of how furosemide is going to be producing the useful for a treatment with heart failure. It decreases blood volume. Beautiful. Moving on to the next drug, buddy. What's the second drug which is used for the treatment of acute heart failure? I have told 𝗏𝗏𝗃𝗏. What exactly is 𝗏𝗏𝗃𝗏? 𝗏𝗏𝗃𝗏 is a selective beta-1 agonist agent. 𝗏𝗏𝗃𝗏 is a selective beta-1 agonist agent. The name is little bit vary, guys. It contains DO in it, but doesn't have any dopaminergic activity. It's purely a beta-1 agonistic drug. 𝗏𝗏𝗃𝗏, similarly, we have 3 other drugs, buddy. It is not used for heart failure, but I just want to make sure that you guys are not getting confused with those drugs. We have dopamine. Dopamine also can be used for heart failure. We have 𝗗𝗃𝗃𝗪. We have 𝗗𝗃𝗪 and phenol-dopam. There is something common between all these drugs, buddy. All these will be having do in its name. It appears like all these drugs will be having dopaminergic activity. Yes, but not all. For example, 𝗏𝗏𝗃𝗏. 𝗏𝗏𝗃𝗏 has got pure beta-1 agonistic property, whereas dopamine has got different doses, buddy. At low doses, it behaves as dopaminergic agonist. At medium doses, it behaves as beta-1 agonist. And at high doses, it behaves as alpha-1 agonistic agent. We have 3 different doses of it, so no need to worry because here we don't usually use dopamine for treatment for heart failure. We can use if a patient's blood pressure is extremely low. 𝗏𝗃𝗪 is a drug which is a D1 agonist agent, and also it has got beta-2 agonistic activity. Phenol-dopam is a D1 agonist with alpha-2 agonistic property. See, we have given 4 major drugs over here, and these drugs will tend to be increasing the cardiac contractility. Primarily, I'm talking only about 𝗏𝗏𝗃𝗪, buddy, because it is being used currently. It has got a quicker and a faster onset of action. When you administer 𝗏𝗏𝗃𝗪, the cardiac contractility is going to be increased because we all know the cardiac muscles. Consider this is the cardiac muscle cell. On the cardiac muscle cell, we have a G protein coupled receptor. G protein coupled receptor, which is beta-1 receptor. This is cardiac muscle cell. On the surface, we have beta-1 receptor. Whenever 𝗏𝗏𝗃𝗏 is administered, it will bind with this receptor. So what happens? We all know that beta-1 is a GS coupled receptor. GS receptors means intracellularly, it is going to be activating adenylyl cyclase. This is a concept which we have learned from general pharma. Even if you don't know, don't worry. That's what I'm explaining right now. So it's going to be stimulating adenylyl cyclase. From adenylyl cyclase, there will be increased cyclic AMP, which in turn will be producing increased cardiac contractile force. This is responsible for positive inotropic responses. Is that clear? So 𝗏𝗏𝗃𝗪 will be interacting with beta-1, thereby the cardiac contraction is going to be increased. With this, we can prevent the patients from landing up in any further symptoms. What is the third drug which we have written? Milrinone. The third drug which we have written is milrinone. What exactly is milrinone? I'm sorry. Am I audible? Like, yeah, I hope I'm audible. Yes, okay, thank you. So let's talk about milrinone, buddy. Milrinone is, it's an inodilator agent. From the name itself, we can come up. It is an inodilator agent. What is the mechanism of this inodilator? Inodilators are nothing but drugs which tend to inhibit phosphodiesterase 3. These are phosphodiesterase 3 inhibitors. So what happens if phosphodiesterase 3 is getting inhibited? It's a simple logic. If phosphodiesterase 3 is getting inhibited, there will be increased cyclic AMP. And why is that? Because just in the previous page we have written cyclic AMP will be broken down to AMP with the help of an enzyme called as phosphodiesterase 3. Cyclic AMP will be broken down to AMP by phosphodiesterase 3. Good. I think I'm seeing some questions. Sorry that there's some issue with the internet or not. Just now the messages are getting updated. Is there any contraindications for furosemide? At present, there is no direct contraindication, but we can use it for acute pulmonary. Sorry, give me a minute. At present, for heart failure, there is no absolute contraindications. We can give furosemide for any of these conditions. For acute conditions, we have to save the patient. No. Sorry. Cyclic AMP will be broken down to AMP by phosphodiesterase 3 enzymes. Well, that is getting inhibited by these inodilators. So what will happen? There will be increased cyclic AMP, which in turn will be increasing the levels of cyclic AMP in terms of vascular smooth muscles and also in terms of cardiac muscles. In vascular smooth muscles, it produces vasodilatation, whereas in cardiac muscles, it will increase the cardiac contraction. That's why we used to call these drugs as inodilator agents. That's why we call these drugs as inodilator agents. It will produce positive inotropic and it will produce vasodilatory phenomena. Good. Now this drug, milrinone, we also have some derived drugs called as vesnarinone. We also have some derived drug called as vesnarinone. These both drugs are used in practice, buddy. Used only for acute heart failure. It is never used for chronic heart failure patients. It is never used for chronic heart failure, used only for acute heart failure. Why? Because in terms of chronic heart failure, if you give drug on a long-standing basis, patients might develop arrhythmia, and because of arrhythmia, patients might die. That's why this is a drug which might increase mortality when given for a longer duration of time. So it is always not recommended to give this drug for a longer duration. Just give it for a shorter duration. Only for acute heart failure, we can administer milrinone. We have, I think I'm looking at into the options also, enamrinone. See, enamrinone was used previously, but now enamrinone is not used. We have a drug called as enamrinone, which is not used currently because of very severe thrombocytopenia. Enamrinone is associated with very severe thrombocytopenia. That's why we don't use enamrinone. We only have milrinone and vesnarinone. Good guys. So we have seen about the pharmacological perspectives of those drugs which can be used for acute heart failure. What about the pharmacology of drugs used for chronic heart failure? In terms of chronic heart failure, we have the first one, which is RNA drugs. No, let's talk about those RNA drugs. Angiotensin receptor neprilysin inhibitor. We'll discuss that in a few minutes. First, let's talk about RNA drugs. See, consider here is where a cell is, right? This is just like a compensatory mechanism, buddy. Whenever there is too much fluid which is getting accumulated inside the body, right? For example, your blood volume is getting increased out because of more sodium and water retention. The body has to let out that water. How it is going to be letting it out? By releasing a physiological molecule called as natriuretic peptide. So from the name itself, you can identify, guys, natriuretic peptide are those molecules which is going to be excreting out sodium and water. Yes. So we have natriuretic peptide molecules, might be of two major subtypes, atrial natriuretic peptide and brain-derived natriuretic peptide molecules. C-type natriuretic peptide is primarily not involved in this particular phenomenon. In pathophysiology of heart failure, C-type natriuretic peptide is primarily not involved. We only have two types, atrial natriuretic peptide and brain-derived natriuretic peptide. These two molecules will bind with some receptors called as natriuretic peptide receptor type A. Whenever ANP or BNP binds with the receptor, intracellularly, this receptor is bonded with guanylyl cyclase. The function of this is to convert GTP to cyclic GMP. The function of natriuretic peptide receptor type A is to convert GTP to cyclic GMP. This in turn is responsible for vasodilatation and natriuresis. Increased sodium and water excretion is going to be seen with cyclic GMP. Good. Now, unfortunately, this is not going to be happening on a longer duration because we all know these are just, after all, peptide molecules. Peptides will be fastly broken down by peptidase enzymes. Peptides are fastly broken down by peptidase enzymes. Well, that's why we have an enzyme called as neutral. We have an enzyme called as neutral endopeptidase enzymes. This neutral endopeptidase enzymes will quickly break down ANP and BNP. Good. Because it is fastly getting broken down, the peptides are not getting accumulated. Well, that's the reason why this natriuresis or this vasodilatation is not long-lasting in lots of patients. What if we find some methodology to inhibit that particular natriuretic peptide, neutral endopeptidase enzymes? If I inhibit the metabolism, ANP and BMP's half-life is going to be increased. Continuous interaction with the receptors, which will produce more natriuresis and also more vasodilatation. What are the drugs which we have? We have certain ANP, atrial natriuretic peptide analog agents. We have certain BNP analog agents, drug molecules which are very similar to those surfaces. ANP analogs, we have 𝗘𝗄𝗃𝗏. BNP analogs, we have 𝗬𝗏. BNP analogs, we have 𝗬𝗏, but most importantly, we have this neutral endopeptidase, which is also called as neprilysin. Neutral endopeptidase, also called as neprilysin, that is getting inhibited by trill drugs, which is 𝗧𝗶𝗺𝗃𝗏. Yes, but trill drugs. Gopinath, you are right. Trill drugs. So neprilysin is an enzyme which is inhibited by 𝗧𝗶𝗺𝗃𝗏. So what we have found is we have started giving an AC inhibitor in combination with NEP inhibitor. AC inhibitor in combination with NEP inhibitor, and we have certain ARB plus NEP inhibitor given together as combination. What exactly is this AC inhibitor and what exactly is this ARB? I will explain that in a basic concept. Whenever the renal blood flow, whenever there is a decreased renal blood flow or blood pressure, whenever there is a decreased renal blood flow, the juxtaglomerular cells, juxta means nearby, the cells which are nearby the glomerulus will get stimulated, which in turn will be releasing renin. Because of the release of renin, angiotensinogen will be converted to angiotensin 1. Angiotensinogen will be converted to angiotensin 1. Angiotensin 1 in turn will be converted to angiotensin 2 by angiotensin converting enzyme. This angiotensin 2 in turn will interact with its receptor called as AT1 receptor, which is responsible for sodium and water retention and vasoconstriction. How this is directly producing sodium and water retention? It will not produce it directly. It will stimulate the secretion of aldosterone. It will stimulate the secretion of aldosterone. This aldosterone in turn is going to be responsible for sodium and water retention. Whereas angiotensin, angio means blood vessel, tensin means tension. Angiotensin itself will produce vasoconstriction. Not only that, this is also responsible for remodeling. Cardiac remodeling also will be there due to this accumulation of angiotensin. Now, what we do, guys, we have certain drugs which are inhibiting this whole process. We have certain AC inhibitors called as prill drugs. Drugs name which are ending with prill, captopril, enalapril, lisinopril, perindopril, all the prill drugs. We have some drugs which might block the angiotensin receptor. These are simple body. Angiotensin receptor antagonist agent, ARTAN drugs. Angiotensin receptor antagonist agents. Some of your professors would feel happy to call it as sartan drugs. Sartan drugs are nothing but, again, ARTAN, angiotensin receptor antagonist agents. So these two drugs are there. And these two drugs, if I give it, the angiotensin and aldosterone's levels is going to be compromised. So thereby, we can prevent a major response to be happening. Sodium and water retention can be prevented, vasoconstriction can be prevented, and cardiac remodeling also can be prevented. Well, that's why we give these drugs in combination with NEP, in combination with the neutral endopeptidase inhibitors. The first one is called as Trilart. We have a drug called as 𝗗𝗏𝗃𝗏. 𝗗𝗏𝗃𝗏. So these two drugs, when given together, your AC inhibitor is going to be blocking up the RAS system, whereas NEP inhibitor will be stimulating your peptide molecules, natriuretic peptide system. Both of this will act together, that will be used in treatment for heart failure. But this 𝗗𝗏𝗃𝗏 produces very severe angioedema. Started producing very severe angioedema than the original AC inhibitors itself. That's why we don't use this drug currently. Instead, we have ARB in combination with NEP inhibitor, which is nothing but ARNI drugs, angiotensin receptor and neprilysin inhibitor given as a combination. And that drug is valsartan in combination with sacubitril. Valsartan in combination with sacubitril, well, this is currently the preferred drug in treatment of a patient with heart failure. Even the latest edition of Harrison's 21st edition also tend to say the same thing. The preferred one is going to be RNA drugs, but we have some like contraindications. For some patients, we cannot administer RNA. So how do we proceed further with that treatment, buddy? So whenever a patient is under therapy or the patient's acute symptoms are getting weaned off, now the patient has been diagnosed as chronic heart failure. We have to treat the chronic heart failure. How do we do that? We give an RNA drug, angiotensin receptor neprilysin inhibitor. But if the patient's systolic blood pressure is less than 100 millimeter of mercury, if the patient's systolic blood pressure is less than 100 millimeter of mercury, or if the patient has previously landed up in angioedema due to any of the angiotensin receptor agent-related drugs, then see, this drug might be producing angioedema. RNA drugs will be producing angioedema. AC inhibitors will also be producing angioedema. So if a patient is producing any of these symptoms, then we can purely give an ARB. We can purely give an ARB without combining it with NEP inhibitors. Good. Now again, if a patient is suffering from hyperkalemia, if the same patient is suffering from hyperkalemia or the patient is suffering from renal failure, I cannot give both of these drugs because both of these drugs will produce further renal damage. In those conditions is where we are going to be opting up for the other BSAM drugs. What are the other BSAM drugs, buddy? B is for beta blockers. Beta blockers will be always given in combination with all of these drugs. Don't worry for it. SAM drugs, what are the SAM drugs, buddy? S is for SGLT2 inhibitors. A is for RNA and AC inhibitors, which we have discussed about till now. And the last one is MRA, mineralocorticoid receptor antagonist agent. We also have one more drug, which is currently found to be very much less effective in terms of Indian population, and that is BIDL drugs. BIDL is nothing but, it's a bidilator. We give an arteriolar dilator and a venodilator together. This arteriolar dilator, which we prefer to give, is hydralazine. Arteriolar dilator, which we prefer to give, is hydralazine, whereas venodilator is ISDN, isosorbide dinitrate. This drug given in combination is called as BIDL or bidilator, dilates both arteries and the veins. Currently, it is found to be less effective in Indian populations, mostly effective in African populations. But again, we still have that drug under the list, which can be used for the treatment of certain patients. Now, what about this SGLT2 inhibitors, buddy? SGLT2 inhibitors are sodium glucose transporter type 2 inhibitors. Example, we have gliflozin agents. Drug's name is gliflozin agents. Out of all the gliflozins, we use empagliflozin. That has been found to be one of the better drugs in treatment of a patient with heart failure. Empagliflozin, understand this logic. If a drug name contains GLI in its name, If a drug name contains GLI, it is a glucose inhibitor agent. If a drug name contains GLI, it is a glucose inhibitor. And flows in, which means it's going to be increasing the sugar flow in the urine. Sugar is going to be let out in the urinary flow. Remember with that mnemonic. So both of the glucose is going to be excreted out. Also water is going to be excreted out. So thereby the load on heart is going to be decreased very much higher. Right? So this is the primary concept. And this drug itself might induce decay. This drug itself might induce diabetic ketoacidosis because faster excretion of ions. Patients might land up in ketoacidosis. So patients who are more prone to land up in decay should not be administered SGLT2 inhibitors. One important contraindication for it. The next one, we have MRA. What is MRA? Mineralocorticoid receptor antagonist. Mineralocorticoid receptor means angiotensin receptor blockers. That's the other name is MRA molecules. MRA drugs, we prefer to give eplerenone. The MRA or mineralocorticoid receptor antagonist, which we prefer to give is eplerenone. We not prefer to give spironolactone. We don't prefer to give spironolactone because it is associated with gynecomastia and erectile dysfunction. Because of the sexual adverse effects, we currently not prefer to give spironolactone. We prefer to give eplerenone. Eplerenone, remember with this mnemonic, ren means it has got renal activity. Ren means it has got renal activity. Good. These are all the drugs which we currently use in management for acute heart failure and also for chronic heart failure. But we have to know one major point, and that is one drug which we currently don't use in practice, but it is still there in the market. That is digoxin. Gopinath is saying about ENaC drug. ENaC drugs, usually we don't use it here in treatment of heart failure, buddy. We have some ENaC blockers like amiloride and triamterene. Those drugs, we don't use it for heart failure. This eplerenone is not an ENaC drug. It is an aldosterone receptor or mineralocorticoid receptor antagonist agents. The last one is digoxin, buddy. See, the mechanism of action of digoxin is considered here is where the cardiac muscle is. Good. On the cardiac muscle cell, there will be a specific transporter called as 𝗬𝗑𝗏. There will be a specific transporter called as 𝗬𝗑𝗏. Sodium, potassium, ATPase pump. Sodium, potassium, ATPase pump. The function of this is to produce efflux of sodium and influx of potassium. Because ATPase pump, which means movement is happening against the gradient. Sodium is moving out and the potassium is coming in. That's the function of this particular sodium potassium ATPase pump, which exactly is inhibited by digoxin. So digoxin will be inhibiting it. तो क्या होगा? अगर सोडियम पोटेशियम एटीपीएस पंप ब्लॉक हुआ तो सोडियम बाहर जाने का तरीका नहीं है. Sodium will not be moving out. Sodium will be accumulated more inside the cells. Sodium will be accumulated more inside the cells. We have one more transporter which is situated on the cardiac muscle cell called a sodium calcium exchanger pump. Sodium calcium exchanger pump. The function of this pump is to produce influx of sodium and efflux of calcium. Influx of sodium and efflux of calcium. So there is more amount of sodium which is getting accumulated. So this sodium influx will not happen. Automatically, this gradient itself will be blocking the sodium calcium exchanger pump. When the sodium calcium exchanger pump is getting inhibited, sodium is not coming in good. Calcium is not also allowed to be let out of it. Calcium will be accumulated more inside the cells. Good. Now this calcium which is present over there, we have the sarcoplasmic reticulum. We have the sarcoplasmic reticulum. On the sarcoplasmic reticulum, there will be two separate kind of transporters. The first one is called as ryanodin receptor, RYR type 2 receptor. Ryanodin receptor or ryanodin receptor. The second one is called as 𝗟𝗃. Second one is called as 𝗟𝗃. With the help of 𝗟𝗃, the calcium which is been released, which has been accumulated on the cytoplasm, it will be taken up inside the sarcoplasmic reticulum and the calcium will be stored inside those areas. See, it's a simple logic, buddy. See, we have the cardiac muscle. When the cardiac muscle is contracting, you know what happens? The calcium which is present on the extracellular area will come and bind with this ryanodin receptor. Whenever ryanodin receptor is getting stimulated, that ryanodin receptor will produce more release of all stored calcium from the sarcoplasmic reticulum. Sarcoplasmic reticulum contains calcium which is stored in it. Whenever this calcium which is released binds with ryanodin receptor, it will produce more amount of release of those. Now what happens? This calcium in turn is responsible for this sarcomere. Now we have this actin myosin filaments. Walkover will tend to occur, so thereby the cardiac muscle is going to be contracted. So this is what happens whenever the cardiac muscle is contracting. Good. When the cardiac muscle is ready to contract, no, for systole, when the cardiac muscle is ready to contract, this calcium will bind with, because that only then ryanodin receptor will be expressed out. Calcium will bind with the ryanodin receptor, which will produce a burst of all stored calcium will be released, which in turn will be producing activation of myosin, actin, leading on to contraction. Thereby cardiac muscle is contracting. Because of that contraction, what happens? The blood is going to be thrown out. Now, when the muscle is going to be relaxed during diastole, you know what happens? During diastole, calcium should not be there on the cytoplasm. Am I right? If calcium is there on the cytoplasm, it will bind with the ryanodin receptor, leading on to release of more calcium. Then the cardiac muscle cannot relax. In those conditions, when the complete contraction tend to occur, there will be expression of 𝗟𝗃. Because of that 𝗟𝗃, calcium will be gaining entry back. All the calcium which is released, it will gain entry back inside the sarcoplasmic reticulum. During those areas, calcium will not be there, so the cardiac muscles will be relaxed, which means diastole will tend to occur. Now, after that, what happens? After the calcium is getting loaded, again, the cardiac muscle is ready for contraction. The calcium from the extracellular area will gain entry inside the cell, which will stimulate the ryanodin receptor. All the calcium will be let out. Then the cardiac muscle will be contracted. Now, what will happen after that? All the calcium has to be taken back inside the sarcoplasmic reticulum by 𝗟𝗃. So there's going to be an equivalent action between your ryanodin receptor and the 𝗟𝗃, which is 𝗟𝗃 is responsible for taking up the calcium, storing it inside, and ryanodin receptor is responsible for calcium-induced calcium release. Good. So this will be happening during diastole, whereas this will be overactive during systole. Now, any drug molecule, if you administer, be it your digoxin, especially in this case, this by preventing sodium-potassium ATPase pump, it will prevent the calcium from leaking out. So thereby, calcium will be accumulated more and more and more inside the sarcoplasmic reticulum. Every time the cardiac muscle is contracting, there will be more contraction of the cardiac muscles. Thereby, it is going to be increasing the cardiac contraction. Is that good, buddy? That's how digoxin is producing its mechanism. Now, this digoxin, because it is increasing the calcium levels inside those cells, it might be producing lots of adverse drug effects. Digoxin will be producing lots of adverse drug reactions, primarily arrhythmia. Primarily, arrhythmia will be developed. Most commonly, patients might develop pulses bigemini. Pulses bigemini might be expected, and ventricular extrasystoles. Ventricular extrasystoles might be developed because of this digoxin. Apart from that, it also produces other adverse effects, like non-cardiac adverse drug effects. It also produces certain non-cardiac adverse drug effects like xanthopsia. Xanthopsia means yellow vision, buddy. Xanthopsia means yellow vision. Why? Because simple one, buddy. This drug, like your digoxin, is actually derived from a plant called as yellow oleander. This is derived from a plant called as yellow oleander, and this in turn will be producing yellow vision, yellow discoloration of vision. Good. And it also produces nausea, vomiting, diarrhea, anorexia might be developed, and patients might develop mesenteric artery occlusion. Mesenteric artery occlusion, which is a recently reported one, buddy. mesenteric artery occlusion, and patients might develop hyperkalemia. Patients might develop hyperkalemia as an adverse effect of digoxin. Why? Because we have the same 𝗬𝗑 in the kidneys in the distal convoluted tubule. We have the same 𝗬𝗑 in the distal convoluted tubule. So what happens, buddy? What is the function of sodium potassium ATPase pump? Sodium is going to be moved out, potassium is going to be moved in. So we have the blood vessels, we have the distal convoluted tubule, and here is where the urine is. On the surface of distal convoluted tubule, see, here is where the blood vessel is. We have distal convoluted tubular epithelial cell, and we have the urine over here. On this surface is where your 𝗬𝗑 is. Here is where 𝗬𝗑 is, sodium potassium ATPase pump is situated there. Now the function of this is what? To produce efflux of sodium and influx of potassium. That's the function of it, right? Because ATPase means opposite action is going to be happening. Normally, sodium is an extracellular ion. When a channel is open, there must be influx of sodium. That's the common thing which should happen. But here it is going to be inverse. That's the concept of an ATPase pump. What if digoxin tend to inhibit this 𝗬𝗑 also, which is present in the distal convoluted tubule? Just look into what happens to potassium. Potassium will be accumulated, thereby it will be producing hyperkalemia. Thereby digoxin might be producing hyperkalemia. Good. With this, we complete the most important set of drugs which can be used in treatment for heart failure. I have explained about the pharmacological perspectives of every individual drug. I hope just a small revision of it, buddy. A small recap of it. What are the drugs which we currently have in treatment? What are the drugs which we currently have? We can treat the patient with oxygen, furosemide, dobutamine, and milrinone. Chronic heart failure, we can give beta blockers, SGLT2 inhibitors, ARNI drugs, or MRA drugs, mineralocorticoid receptor antagonist agents. We have a mnemonic for that, BSAMs. Apart from that, we also have AC inhibitors. We also have certain other drugs like ivabradine, but not used more commonly. We explained about the first drug, furosemide. Dobutamine, how it functions, we explained it. Milrinone, how it functions, we explained it. Then we move on to the chronic heart failure. We explained about what exactly is neprilysin inhibitor or neutral endopeptidase inhibitor. Then we explained about what is an AC inhibitor, what's an ARB, how the functions are, and what exactly are the adverse effects and the contraindications for administering those drugs. What exactly is SGLT2 inhibitor, what is an MRA. Apart from that, we also gave some explanation regarding digoxin, how calcium is gaining entry with the help of 𝗬𝗑 and with the help of ryanodine receptor, and how the contraction occurs and what are the adverse effects of digoxin, buddy. With this, we wind up the session. Thank you so much, everyone who were there today. And we'll have one more session, and you will be getting the communication of what is the next session, and it will be there soon. Thank you so much, and bye-bye. Good night.